Hi there. Let's finish off this chapter by looking at how does all that we have learned about the microscopic structure of the bone really look like. We will also consider how bone anatomy relates to the stress as a force controlling the growth of a bone. Finally, we will look at the formation of bone and some clinical relevance to what we have learned. So last time we finished, I think, with a slide that looked a little like this. Here we see osteoblasts, which were the cells making the new bone, osteocytes, which were the mature adult bone that osteoblast turns into as it gets trapped inside all the new bone that it has built, and finally osteoclasts, which broke down the old bone. Now let's see if we can identify evidence of these processes by looking at the microscopic view of the bone. What we have here is a microscopic image on a high magnification of the compact bone. We can see a transverse section of a single osteon. And what I think is going to be useful for us is to look at the diagrammatic representation of this. So here we go. This is what we just saw, a real microscopic image of, but with a little bit more detail, with artists having added some important structures that we will want to know. We will be focusing on the compact bone region, which fills the majority of the drawing, starting from the left-hand side. At the right edge, we can see a little of the spongy bone. So, within the compact bone, I want us to focus on a single osteon. This was, if you remember, the result of an osteoblast having made new bone all around it, with it eventually becoming trapped inside it and now turning into a mature osteocyte. And we see that in the middle of an osteon, we have a central canal. These are where blood vessels, nerves, and lymphatic vessels run within the bone. Remember, bone is very much a living tissue that is constantly being broken down and regenerated, and therefore needs a blood supply. And we see perforating canals running more horizontally. They connect different central canals to each other. What I want to discuss next kind of piggybacks on all that we have talked about O cells before. So we remember that some of the bone was being constantly made by the osteoblasts, and once mature they get trapped inside of the new bone that they have made around them and become osteocytes, while osteoclasts were constantly breaking down old bone so that it can be relayed to meet the new requirements. So this is a very much a dynamic process, making bone formation and breaking down old bone a constant process. And this is exactly what happens. As bone is exposed to a mechanical stress, it has two options. If the stress is too much, it can break the bone. In this example, the neck of a femur. But more ideally, if the stress is not as high, it will trigger for the bone to go through this process of breaking down old non-functional structures and laying down new, better functioning bone. And this is what we can see that has happened here. New fiber-like bone has been laid into the spongy bone, making it mechanically stronger to meet the demands, and by that I mean the forces that the particular bone area is exposed to. This is why you're running, practicing sports that generate an impact to the bone, and all day-to-day activity, as long as it is not too extreme, is good for your bones. The mechanical stress in suitable amounts actually strengthens bone, especially to face the compression and tension to that kind of forces that it is exposed to. And what you might find surprising is that bone anatomy is in this way very responsive to the physiological bending stress, for example, that is exposed to. And if you think about it, this is part of the reason why we want, for example, for the patients who have had a hip replacement, out of their hospital bed, walking on that hip as soon as possible, even if it means that we have to give them stronger pain medication. It is this mechanical stress that will strengthen their bodies and bones and the attachment of this new hip replacement to the bone. The other part of the story that I wanted to tell you about relates to this, the long bones and how they grow and remodel during the youth. It was the epiphyseal plate in the young where much of the lengthwise growth of the bone took place. And we see, especially in the young, a lot of bone remodeling taking place during this age. And then when you grow older, this epiphyseal plate turns into epiphyseal line as the growth is no longer as active. So again, the bone is very much a dynamic and changing and living structure. And this cartilaginous plate that we see in the young, here is what I want to draw our attention into next. But before we talk more about it, I just want to show you that there are distinct layers in it. And the reason why this cartilaginous plate is something that I want us to look at is the process of endochondral ossification. How much of the bony skeleton is formed in the young. So, the hyaline cartilage becomes gradually replaced by the bone. Here in the picture, we will see a development of one long bone from week 9 of pregnancy all the way to the birth, and from childhood to adolescence. And in this process, we have both primary and secondary ossification centers. But that is not the only way how bones form. We also have intramembranous ossification. In this, the fibrous membranes are replaced by bone. You can consider it as if it is hardening, as seen in this figure. So, these are our two types of ossification. Now, the next theme that I want us to talk about is the bone fractures. A fracture is simply a break in the line of continuity of the bone. And there are many ways how we can classify these fractures. Let's go through some of these. In the first case, we might be looking at the position of the bone ends after the fracture. In non-displaced fracture, the ends remain in their normal position so that the fracture may not be as obvious if we are simply looking at the line of continuity on the outside. Whereas in displaced fracture, we see that the ends are clearly out of alignment. In the second classification method, we consider if the break is complete, meaning that it is all the way through the bone, or incomplete. In the latter, then, the fracture does not run all the way through. In the last type that I'm presenting here, our interest is in the fact if the bone comes through the skin or not. In an open fracture, we can see at least one of the bone ends, while in closed fracture, the skin remains intact. These can be referred sometimes also as simple and compound fractures. There are also other classification methods for the fractures. Your textbook does a good job discussing these, so I will leave it up to you to review them independently. Instead, I want us to see how the bone fracture heals. And here we see that there is initially going to be a mass of clotted blood. The site is swollen, painful, and inflamed. Then collagen fibers form to the site connecting the broken ends. This is followed by the bony material forming starting from approximately 1 week from the fracture, depending on the type and extent of the fracture, of course. Please note that at this stage, the new bone is still spongy bone in a structure. And finally, the bone hardens as a process of building and breaking bone continues, as we saw earlier in this video. Now it becomes compact bone too. Although I am leaving the study of clinical conditions to your independent work, I do just briefly want to introduce you to osteoporosis. This is the condition where the osteoclast activity of the bone breaking down exceeds that of osteoblasts, which make new bone. This is especially relevant for women as the change in the estrogen levels after menopause causes a higher risk. Of course, also lifestyle matters play a significant role. Here, I have given quite an extensive list for you. One common side of an injury in the osteoporosis is the spine and neck of femur being broken. Remember, this is largely spongy bone and therefore potentially more vulnerable. And one of the interesting debates that I have been part of as an anatomist has been the common misconception that in patients with osteoporosis, they fall and then break a hip. Turns out this is not the case most of the time. I was involved in a hospital setting where we were getting all these bed-bound elder patients with osteoporosis, among other conditions, and there were hip fractures in these patients even though they were in bed. And initially, there were some of the staff, I will not name if it was MDs or nurses, who were telling that it has to be that these patients had gotten up, fallen, broken their hip, and then somehow gotten back to the bed. It does not work that way. When you break your hip, you really are not going to be climbing around back to the bed. So this is one example how anatomists can contribute significantly to our understanding of disease processes and hospital practice. And I hope that you consider careers in the fields that you might not have initially considered, such as anatomy. I at least have had a very varied and rewarding career in this field. So remember, the hip breaks first, and as a result, they fall. Finally, I guess that we should finish this topic by considering what can we do to avoid issues. Well, at this point, where you are likely in your life, it's all about prevention. So getting the calcium in diet and bones being exposed to sufficient mechanical stress. As we are finishing off this chapter, I want to mention a few words about what happens when you become older. Well, of course, there is likely more bone weakening. What plays a role especially is the genetics, calcium, and vitamin D as well. And I am sorry to say, if you are a female and white, you have an increased risk of issues with skeletal system as you age. So, that's it for our chapter on bones and skeletal tissues. In the next chapter, we will take this information and start to apply it into our study of individual bones. I will see you then.